Hello and welcome back to my channel. If this is your first time here, I'm Nurse Alyssa, and today we're going to be doing another case study. So today's case study is about a malignant ulcer. So that is a cancerous ulcer. These are usually non-healing due to it being cancerous. So let's get started, guys. So the patient's name is Helen Carter. Now, this once again is a made-up profile. I don't use actual patients. They may be based off patients I have had, but names and details are changed, okay? So Helen has a malignant ulcer with 4+ exudate and a foul odor. And her history, so she has a history of breast cancer. She was diagnosed 3 years ago, which was treated with a lumpectomy. So they did remove it, chemotherapy and radiation. Unfortunately, she has developed a reoccurrence of the cancer in her right breast and axilla 6 months ago. Over the last 2 months, she has noticed the appearance of an ulcer on her right breast that has progressively worsened in depth and size. So the wound initially started out as a small firm area, but it developed into a large necrotic lesion that is not responding well to conventional wound treatment. The ulcer is measuring 6 by 8 with irregular borders and is characterized by excessive necrotic tissue with a centralized area of yellow slough surrounded by redness and swelling. The ulcer is producing 4+ exudate, which is described as thick yellowish, and it does have a foul odor. Miss Carter is also experiencing general fatigue, weight loss, and occasional night sweats, which is rising concern for systematic involvement of the cancer. So her past medical history, so once again, she did have the breast cancer and that was diagnosed 3 years ago. She does have chronic venous insufficiency, hypertension, osteoarthritis, and she does not have any known drug allergies. And so she is on medication for her cancer, hypertension. She takes acetaminophen for pain, and she is on furosemide for the venous insufficiency, so for the edema that's in her leg. So when it comes to wounds, we want to look at the whole patient and not just the actual wound itself. There is so many factors. It's definitely multifactorial. That's why we look at the whole patient and not just the hole in the patient, because we have to see everything that's going on to be able to treat this wound, because we try to correct the cause. Now, in this case, it is going to be categorized as a non-healing wound due to it being a cancerous lesion. So we'll now look at the physical exam, and then we'll get into the actual wound assessment and choosing the actual dressing that we're going to put on. So for physical exam, the general appearance, Miss Carter appears older than she has stated. She is in moderate distress due to pain and discomfort from the ulcer, and she is on acetaminophen, so we already know that that's not covering it. And then she also does have a stable vital sign. Cardiovascular, so she does have a regular heart rhythm, no murmurs. Peripheral pulses are weak in both lower extremities, especially on the right side. Respiratory, clear breath sounds bilaterally, no wheezes or crackles. Abdomen is soft, non-tender. The extremities, once again, the right breast has a large necrotic wound on it. The area is painful to touch with moderate tenderness and warmth. The left breast, there's no significant findings. Neurological, there's no focal deficits. So the diagnostic workup that we did, there was signs of infection. So there was a wound culture taken and it was positive. So there would have been a culture and sensitivity done, and that would show what type of antibiotics the patient should be on. The patient did have blood work. The white blood cell count was high, likely due to infection, and also the C-reactive protein suggests inflammation. There was also a breast ultrasound and CT scan, and there was no sign of metastasis to distant organs. So the diagnosis, obviously the diagnosis is a cancerous lesion in the right breast due to the cancer. So now let's get into my actual wound assessment. So putting all this information onto the paper so we can see it a little bit easier. So the type of wound is a malignant wound. Next to it, it always says, how do we treat this? Okay, so odor and drainage management, also infection management. We want to make sure that we are controlling those three things with malignant. It is a non-healing wound, so this isn't something that we're going to be able to heal, but we need to manage the symptoms and issues that arise with the, just to make it a little bit more comfortable for the patient. Wounds are never going to be a comfortable thing, but if we can reduce the pain, reduce the odor, reduce the amount of exudate coming out of it, just kind of dry it out, manage it to the best of our abilities, that's all the patient can ask for. So the drainage type is a thick yellow, just purulent drainage coming out in large copious amounts, and there is also a foul odor. A lot of times with these malignant ulcers, there is a foul odor. Very, very common. Determining infection, we already did the wound culture that was positive. So the patient will be going on a IV or oral antibiotics that is up to the doctor. And then we also normally use a topical antimicrobial. But I do have this lovely chart here. It is the NERDs and Stonies. If you're not sure what that is, it's a chart that NERDs, it shows local infection, and Stonies shows deep spreading infection. If you have 3 or more on either side, it's indicated of a clinical infection. That wound cultures are obviously a whole lot better because it shows exactly what type of infection is, and it can be treated specifically for that. So I do have here that it's non-healing, exudating, there's debris in the wound, and it has an odor. So obviously for local infection, there is 4 on that side, so it would be treated. And then on the right side, it's increased in size, exudate, it has increased. We have redness and swelling and also smell. So it indicates that there's local infection and it's deep spreading infection that needs to be treated. The pain is a 9 out of 10, and as discussed in her medications, she is already on acetaminophen for the pain, so obviously not working. We need to talk to the doctor and make sure that she gets appropriate medication for this wound because they are very painful and we don't want our patients in pain. Chronic pain is never a good thing. We always have to take the pain for what the patient says it is, and it definitely needs to be treated with something stronger than acetaminophen. So the peri wound, there is the redness, swelling, and induration, and the wound base, it has slough and necrotic tissue. So now we're going to get into how are we going to be actually managing this. So wound care, obviously we have the slough and necrotic tissue. Now with malignant wounds, it's it's a difficult one because we don't want to make this wound any larger. And a lot of times when we're removing that slough necrotic tissue, we're opening it up more. Now, the problem with that is this wound is not healable. It is going to, for a lot of the time, have slough necrotic tissue in the wound. We can do conservative sharp debridement. Now, this is obviously done by a doctor or wound care specialist just to kind of remove some of the excess. We're not, it's very, very conservative debridement here. We're just taking off like the yellowy slough material, just anything that's loose, and we can kind of grab with the tweezers and just take just the dead tissue off. So there's not an excess amount in there. We definitely don't want to take it down too much, but this will just help with the odor and the infection. So really when it comes down to it, we want to dry out this wound because it is non-healing, and we just kind of want to stabilize that necrotic tissue. So dressing selection, we want to obviously balance the moisture. It's way too moist of a wound with 4+. So we want to really remove a lot of that drainage. Cleaning, we're going to clean it with just normal saline and going to avoid harsh antiseptics. Now we're going to be getting into how we're going to actually treat this wound, what we're going to put on it for dressing selection. Now, all the charts that you're going to see in the upcoming slides can be found in my book, Wound Assessment and Dressing Selection. So what we're doing here in this case, exactly in here. So it goes over the wound assessment, it goes over dressing selection, and we're going to see these are the exact charts that are in my book that shows exactly how to choose a dressing, because I've noticed that a lot on my channel that everybody always asks, like, what do I put on this wound? And it comes down to, we have to do our wound assessment and put that into these simple flowcharts to be able to come up with the dressing selection. Now, I've made these charts to make it a whole lot easier to determine, okay, if I have this amount of exudate, I should be using these types of dress. If I have slough, I use these type of dress. And it just kind of goes from there. Infection, odor. It goes over any type of issues that you may be having with the wound, and it gives suggestions of dressings that you can use for that. Okay, so let's go over the exudate amount. So it is a 4+ amount of exudate. So that's our super absorbent pad, our hydrofiber or gelling fiber, alginates, and hypertonic dressing. So those are the type of dressings that we can use. Now, we do need to use clinical judgment also when it comes to these charts, because not everything, once we put it all together, and you'll see at the end, I'll take everything from the charts and put it all onto one page that is actually relevant to our patient. And I'll show you exactly how we narrow it down to our dressing choice. So our next clinical situation is our slough. So we do have slough. It is non-healing, okay? So you can see here on the chart, we have healable or non-healing. It is a non-healing wound. So we want to dry and stabilize the necrotic tissue and prevent infection, okay? And then it has the dressing choice. So gauze with chlorhexidine, or a non-adherent synthetic contact layer with an iodine compound. Okay, so those two will help dry out the wound, the chlorhexidine and the iodine. Now, I do want to say I don't ever mix antimicrobials. So a lot of time, I have come across this so many times, where they're just trying to throw so many things at the wound. The simpler, the better, to be honest. I like to use one product if I can, to manage the wound. And I never want to be using 2 different antimicrobials. Just use one at a time. That's how you're going to get your best result. And then we have our exudate type. So we do have that purulent drainage. So we want to minimize odor, treat infection, and absorb the exudate. When there's infection, normally we do have an increased amount of drainage that does need to be controlled. So as you can see here, we have charcoal, and that will help with odor, and our antimicrobial agents, so gentian violet, methylene blue, honey, iodine, PHMB, and silver. Next up is our infection and wound pain. So infection, it really goes with the purulent drainage. We want to reduce the bacterial burden using our antimicrobial agents, and then the wound pain. So she is in quite extreme wound pain, a 9 out of 10. So we definitely want to be talking to the doctor about that, to get stronger meds, and possibly a topical that we can put on to kind of freeze the area during dressing change. So here's where I put it all together. So this is everything that is related to our patient. So we have the drainage, the slough, the purulent, and the odor. So I like to put it into 2 categories, as you can see off to the right-hand side here. So the most concerning right now, especially to the patient, would be the odor. She likes to be out around people, and she has a very offensive odor to this wound. She doesn't want people asking questions, obviously. She wants that controlled. So very, very concerning for the patient is that odor. So we need to get that under control. Obviously, once we start treating the actual infection, the odor will minimize, but a lot of times malignant wounds, they do have an odor to them. So we want to be controlling that. There is infection, very necessary control. And then secondary, we have our heavy exudate and slough. So they are all equally important, need to be treating them. It's just how I kind of categorize it when I'm looking at the dressing choices. So first off, odor. What do we have for odor? And it's charcoal. really that's what's available. So I usually use Actisorb, and it does have silver with it. So that kind of has the antimicrobial and the odor. So that's covering for both of the odor and infection. Okay. Now we also have the heavy exudate and slough. So what are we going to do for that? I personally would just use a conservative sharp debridement because we're already covering the odor, the infection with a dressing. So we're really just going to, when we wipe out the wound and are cleaning the wound, we're going to kind of try to wipe any of the slough away. Obviously being cautious because this is painful to the patient, making sure they took their pain medication before wound dressing change is done. And then just conservative debridement. Just if there's any pieces that you can just simply cut off, just to get some of that sloughy material out of there because it's kind of stringy and a lot of times you can cut some of the pieces off. Just very, very conservative. And once again, this does need to be performed by a doctor or wound care specialist. And then the heavy exudate. So we need to control this. So we would do that by our secondary dressing. And personally, we're already using a primary dressing, so I would go for the super absorbent pad here. So as you can see, these are the dressing choices that I have chosen. So the Actisorb, it has silver and charcoal in it to help with odor and infection. And then the Extrazorb, this will help wick away all that excess drainage. So the Extrazorb, it does almost have like a diaper technology. So it does wick away and it kind of gels in the inside like a diaper would. And it can hold extreme amounts of X. So for the wound care management plan, we're going to start with debridement. So conservative sharp debridement of the necrotic tissue, just to reduce the bacterial load and eliminate the areas of slough. Now we're just going to do this as needed. It's just very conservative. So every 2 to 3 days, if we see sloughy material that needs to come off, we just kind of take it off very, very slowly. We don't want to do anything extreme here because once again, this is a non-healing wound. Antibiotic therapy. So the doctor did decide that we're going to go with an IV antibiotic and then switch to oral once clinical improvement is being noted. And then we have our topical antimicrobial therapy. So this is our silver and charcoal. So that's going to cover the odor and infection. Pain management. We definitely need something stronger than the acetaminophen that she is on. So morphine or oxycodone, that is up to the doctor to choose, and possibly a topical lidocaine gel for localized pain relief during dressing changes, especially if we're going to be debriding or trying to remove some of that sloughy material. We want to make sure that our patient is comfortable. Pain is definitely a source of stress and anxiety for our patients. So if we can help reduce and minimize that, nobody should ever be in pain. Especially with malignant ulcers, this does need to be managed very well. Now, nutritional support. Nutrition is so important when it comes to healing wounds. If we can optimize the body, put very healthy foods into it, high protein, high calorie, just high nutrition. This is what we need to help with the wound, help the body be in an optimal state, okay? So I do have a book available for anybody. It's on Amazon. It's the Wound Healing Cookbook. So this is very nutrient-based recipes. So there is 20 recipes for breakfast, lunch, and dinner, and they're very nutrient-based, okay? So it has all your vitamins, proteins in each meal to help you just optimize your body, feel the best, and heal if possible. So that is a resource that is available. We have our psychosocial support. So our palliative care team referral is a must. So this will help for emotional and psychosocial support, especially given the advanced nature of the patient's condition. So this is when a multidisciplinary team, obviously very needed. We need all all the support that we can because it's really draining on the patient, psychosocial. A lot of times when they have these cancerous lesions, they don't really want to leave their house. There's an odor to it. They just kind of really put themselves into a bubble. So if we can help manage that, manage the odor, manage the infection, manage the drainage, so it's not going through their clothing, and this really helps them and kind of lifts their spirit. But we do need them talking to someone. So it really has to be this multidisciplinary team. And then our follow-ups, obviously, very regular visit. We need to be consistently removing that sloughy material to reduce the bacterial load. So we're going to be doing very frequent visits, conservative debridement, and monitoring for systematic infection. So after 2 weeks of implementing this plan of care, the wound does demonstrate a reduced amount of exudate, less necrotic tissue and odor within that 2-week period. So she has been on IV antibiotics, and it's really helping with that odor, the charcoal dressing. The exudate is being managed. Being on the IV antibiotics have also helped reduce that infection. So there's not so much drainage to the area. And that's why we're always assessing wounds, because she may not need that extra absorbent pad, and we can go kind of down on the scale of absorbency. So we're always assessing every time we're looking at that wound. We're always looking at the cover dressing and seeing if we can go to something that still absorbs but's more appropriate. So maybe she doesn't need those really thick absorbent pads anymore. The patient has also demonstrated an improved nutritional status. So she started eating just very high quality foods, even though she wasn't really hungry, didn't really want to eat. When she did eat, she made it count. So very nutrient-based foods. And this has helped stabilize her weight. And she verbalizes that she does have a better appetite and she's feeling better. So she's not so stressed. Eating healthy and just optimizing your body to feel the best, it really does help, especially with fatigue and everything that else that's going on within her body. It just really helps. So the patient did express that she's feeling more supported and less distress related to her body image after she started receiving that psychosocial support from hospice. And she does seem to have a better coping mechanism. So as you've seen in this case study, we have gone from the assessment history. We look at that patient as a whole before we ever decide, okay, this is the type of dressing that we're going to choose. We need all the information that we can grab before we ever put a dressing on a patient. So we do need to be cautious. Don't just look at the wound, look at the patient as a whole, have a multidisciplinary team, use your resources. If the patient needed more nutrition support, we could have got that too. Just bringing in all the avenues that we can to help our patients. And that is how we treat the wound. That's how we optimize their bodies to, in this case, if they can't heal, just to feel the best that they can. Okay, that's what it comes down to. Even if it's a non-healing wound, if we can optimize their body to a point where they're feeling their best, they're feeling better, even though this wound isn't going to go away, they can live their best life while they can. That's really what we're looking for. We're just optimizing the body to the peak where our patient is comfortable. Okay, so that's all I have for this video. I hope you did find it helpful. And once again, my book is available on Amazon. If you liked these charts, it is available for purchase. I will put it down in the description below if you are interested. And I will also add my wound healing cookbook if anybody is interested in that, also in the description. So that's all, guys. I hope you have a wonderful day, and I'll catch you in my next video. Bye for now.